Hey guys, Woodruff here. So today I'm going to be doing my long lecture over understanding EKG. Now, EKG is one of my favorite things, so I have a variety of videos over this and breaking down the content different ways, but this is my long lecture for those that maybe need a little bit more help with this topic or kind of want to just see, how do I take people through in my class, or if you're in my class and then you're wanting to kind of go back through, you feel like you missed something, this might be helpful to you. So I'm going to be using this PowerPoint, but I'm also going to be jumping back and forth between this and another document that I have that is like a follow along where we can get practice. Because I find with EKG that it's really hard to just merely like teach it or talk about it. You have to look at it, you have to practice with it. So hopefully this will be helpful to you. Alrighty, so let's talk about the basics. And also, I'll say this is a very hard topic to teach. I feel like I've tried 50 different things and I'm only barely scratching the surface of feeling like I'm teaching it well at all. It's so hard to teach. It seems really confusing to do, but it just takes repetition and practice, just like ABGs. So EKG basics. So let's talk about what we're seeing here. So when we're looking at an EKG, there's, we like to break it down by its parts. So they have what's called a P wave, a QRS complex, a T wave, and then we also have these intervals. The intervals don't come in as much until you get into complex, but I want to introduce them now so that when you get to complex, it's not like, whoa, why didn't Ms. Woodruff bring this up? Because they expect you once you get to that next course to really be able to like remember a lot of the content from the section. So let's start with the P wave. So the P wave is what I call the upright hill. And so it should be pointing up. It should be going up, not upside down. And I always call it the upright hill in front of the pointy thing. That is the official term. If you want to know the legal term, I'm just joking. It's not really the real term, but it's the hill that's before the pointy thing. And what it is it's a sign, the fancy word for it is atrial depolarization or contraction. But effectively what it's telling us is it's telling us the top of the heart has contracted or squeezed. So it's like, this is electricity. So let me back up a little bit here before I get too crazy with this. So there is, there's two main parts of the heart. There's the electrical function, and then there is the pumping or mechanical function. So what we're looking at with EKG is the electrical activity. We're seeing what impulses are being sent. Now, you can have electrical activity and no actual squeeze, but majority of the time, if you have this electrical activity, it is telling us the heart has squeezed. But we want to know where in the heart has squeezed. Is the top of the heart squeezing okay? Is the bottom of the heart squeezing okay? So that's what each of these waves helps to tell us. So like I said, the P wave tells us the top of the heart or the atria have contracted. Then that pointy thing that's next to the P wave is what's known as the QRS complex. So if you hear me talk about the pointy thing, that's what I'm talking about. So this is saying the bottom of the heart or the ventricles have squeezed. And this is what's known as ventricular depolarization. And this is, we really want the both parts of the heart to be contracting, but if any part of the heart needs to be contracting, we need the ventricles to contract. Because if you remember your anatomy, and if you don't, I would definitely go back and watch my video over like assessment and path and like heart, basics and stuff like that. Is that the right ventricle pumps blood to the lungs so that oxygen can get so that the blood can get oxygenated blood, and then the left ventricle takes that oxygenated blood and pushes it out to the rest of the body. So really important job. So the atria are really important to get the blood to the ventricles, but the QRS complexes, the ventricles are your powerhouses. They're the ones that are really pumping that blood to push it out to the most important places, especially when we're talking about the left ventricle, super important. So we should, for everyone who has normal electrical activity, they should have this first hill, that's the P wave, saying the top of the heart has contracted. They have a QRS complex or a pointy thing that says the bottom of the heart has contracted. Then we also have, I'm going to skip the intervals real quick and go to the T wave. Then we have the hill that's after the pointy thing. And again, sometimes the P wave might be taller than the T wave. Sometimes the T wave might be taller than the P wave. Don't get too caught up in it. It's just, is it before or after the pointy thing? And what the T wave is think of this as your toilet. And I'll explain why I call it a toilet here in a second. But this is your resting period. And so this is the period of time. There's not actually necessarily electrical activity happening, but pretty much your body's preparing for that next beat. So this is a resting period. So the reason I call it the toilet is I like the idea of, think of it like when you flush a toilet, that, like, let's say, you go to the bathroom, you flush it, it's going to take a little time to refill. The heart's very much the same, where the heart needs some time to refill after flushing or contracting, so it can prepare for the next flush. And so we worry about, or we talk about the T wave, and this kind of goes into the QT interval, which I'll talk about in a second, is that we effectively, during that relaxation or resting period, we really don't want anything else happening around that T wave. In other words, like my T wave, my toilet, this is supposed to be the time that I'm refilling, refreshing, getting ready for that next beat. I don't want anything happening during that time. I also don't want it to be too long, because like sometimes when you don't want to clog your toilet, so you wipe yourself, you flush some of it, but you still got a little toilet paper left, so then you're waiting for it to fill. But sometimes you're sitting there, you're like, oh, I'm really impatient, you want to flush again. Now if you flush that toilet again, will it actually flush? Depending on how long it's been since you flushed, it probably will flush somewhat, but it's not going to flush as effectively or do like a full flush, and it can actually really mess up your toilet, and sometimes it can end up getting clogged or overflowing, etc. So just like with a regular toilet, we don't want to flush too early. We want to wait till it finishes refilling. And it's the same with the heart, that during that T wave time, we do not want to have any heartbeats happening. We want everything to be resting. We don't want that time to be too prolonged, because again, then my heart can get impatient and be ready to beat, or AKA flush again, and we can end up having abnormal beats. Now for a toilet, the worst problem you might have is like an overflowed toilet, or something, maybe you're not really getting an effective flush, so it's not life or death. But with the heart, when we're talking about this, is it can be a real problem, because what can happen is that if you're trying to do a heartbeat during my toilet time or my resting time, what can happen is they can go into really abnormal rhythms like ventricular tachycardia or ventricular fibrillation, which we'll talk about later. So in other words, we really don't want anything happening during that T time or that T wave time or that toilet time, because that's my resting period. And if you wake up my heart during that resting period, it gets irritable. So it's just something to know. So how that relates to the interval, there's this QT interval, and the QT interval is the space in between. Remember, I have my QRS, but it's the distance between and you can kind of see it here, the distance between my Q on my QRS and then the end of my toilet time or my resting period. And so this is how long it takes, kind of from the start of my ventricle contracting all the way to the end of the relaxation, when I'm getting ready to start that next heartbeat. It's important to know, and you're going to see this in a lot of drug books, is that there's a lot of medications that can prolong that QT interval. And when that QT interval gets prolonged, we can end up having a lot of serious problems, like I said, like those dysrhythmias, etc. So you may have some physicians that maybe ask you to measure or look at the QT interval or keep an eye on it, because maybe your patient's on a lot of medications that prolong that. If my patient's on a bunch of medications that lengthen that QT interval, they're going to be a higher risk for like that toilet flushing again early, or having a dysrhythmia. So I'm going to watch it really closely. Now, again, there's not, like, if you're sitting here and you're already like, oh my God, kill me now, this lady, like she said this was going to be simple and fun. And I haven't mentioned that yet, but by the way, it's going to be simple and fun. But I promise it gets better. But just keep in mind, like, I'm just trying to get you an idea of each part of the EKG, and it'll start to make sense when we put it into scenarios and start really looking at it. So then there's the PR interval as well. And then this will come into much more play when we talk about heart blocks, when you get to complex. But this is the time it takes from the top of your heart to send the message to the bottom of your heart to squeeze. And we like this, like less than 0.20 or less than one big box. And it's important for it to do that, because if it takes too long, like eventually we get into other types of blocks. But when the top of the heart is not sending messages to the bottom of the heart, it eventually can progress to where the bottom of the heart's like, hey man, you're not sending me messages. I'm going to do my own thing. You do your thing, I'm going to do mine. And we really want the top of the heart and the bottom of the heart to be in sync. We don't want them to be doing their own thing. So anyway, But that's the PR intervals. So effectively, with both of these intervals, I think the overall picture that I want you to get here is that there's a certain length they're supposed to be. If my PR interval's too long, I'm worried about a heart block where the top and the bottom of the heart aren't talking. If my QT interval is too long, then I'm worried about dysrhythmias, especially like those ventricular dysrhythmias or sudden cardiac death. Da, da, da. All right. So why are we looking at this crap, right? That's what probably a lot of y'all are saying, because you might not be as excited as I am about this beautiful EKG lesson. But what we are seeing here is we are seeing time. So like I've already spent like the last slide talking a lot about this, about how important time is. So time is such a big thing when it comes to EKG, because that's effectively why there's all these boxes and stuff. We need to know how long it's taking for the heart to talk to each other, how long it's taking for a beat to happen, because all of these are, they indicate that there's something abnormal. If my timing's off, my electricity's off, then that contraction may not happen the way it's supposed to, or it can be a sign that I'm in a dysrhythmia or abnormal rhythm. So at this level, at the adult level, we're not really expecting you to know all of these numbers in depth. You will be expected as time goes on to know more and more of these. And I'm saying this as of right now. Things can always change. So I can't promise you it is possible you could be tested over some of this stuff. But most of what we're testing you over is like, what's a normal PR interval? How fat should the QRS be? Let me see what else, like that kind of stuff. Like those would be the main ones that we test you over, because those are both ones that like actually affect the rhythms, like the P wave size, T wave size, not so much. But really what we want you to know is what's the normal PR interval, because if it's so long, it will cause a block. And then we also get into ventricular rhythms when my QRS gets fat. So we usually like you to know what a normal QRS range is. Now, I'm not guaranteeing or promising that's the only ones you need to know, but those are probably two of the most important ones. But I have some EKG worksheets on my Google Drive that maybe will help you to think of like what are some common or important intervals and distances to know. So putting it all together, we have the top of the heart contracting, and then the top of the heart has to talk to the bottom of the heart to tell it to contract. Then we have the bottom of the heart or ventricular contraction. Then we have this period of time that I'm supposed to be resting. And then don't worry about this U wave thing here. You'll learn about it in complex with MI. And then we have our next heartbeat. So yeah, pretty much top of the heart contracts, bottom of the heart contracts, and then I rest. So that's a lot of stuff. So why don't we get into, what now? And I'm hoping that my picture isn't going to get too crazy here, because I'm sharing my screen a little different. So hopefully it looks okay and it's not blocking anything. If it is, I'm very sorry. I think with ABGs, it's so important with EKG to always have a systematic method. So I'm going to show you my systematic method. Now, I have tried to write algorithms. I have tried to create like a simple, always do it this way kind of method. And I've got to tell you, it just doesn't work. There's too much gray in nursing. But this is the best that I can do when it comes to creating a systematic method. So I'm going to show this and we're going to get some practice. We're going to break down each of these things. So if they don't make sense, we're going to get practice. Don't worry, I promise. So the first step is that I always like to count the rate first. I'll show you how to do that here in a minute. So we want to know, is it fast or slow? Because if I can start breaking down, am I talking about a slow rhythm or a fast rhythm? It can help me to differentiate. Then we want to see, is it regular? Because there's only so many rhythms that are irregular that you're going to really need to know and really have down. So we want to see the distance between that R to R, which again, I'll show you. And then we also want to see, is there regular P waves present? That's kind of a part of that too. If is it regular or not, and what are my P waves looking like? And then we want to, because like pretty much you're pretty much counting the rate, then you're seeing, is it regular? You want to look through each part of your EKG. Start with your P waves. How are they looking? What do they look like? Then you're going to go like the next one to your QRS. Is it skinny or fat? And this is where I told you, this is one of those numbers you'll want to know. We want it less than it should be 0.12 seconds. And I'll have to fix this. Every time I swear that I finally get these PowerPoints all fixed up, there's always some typo and it just kills me and it creates so much work for me. One day I will have my crap together, maybe, but just not right now. So anyway, QRS skinny or fat. So we like it. So this, what do you call it? If the second one's right. So if is it greater than or less than 0.12? which is, almost like it's about like three of the little dots in a box. So, and this tells us if it's the top of the heart or the bottom of the heart problem. So effectively count the rate. We see, is it regular? What's going on with my P waves? What's going on with my QRS? And this helps differentiate. Now, sometimes you're going to go through this and you might be able to figure out what it is in the second step, but I still say go through it all just to confirm, because you never know. So let's start by talking about how we count the rate. So you're going to see different things about this, but the most effective way that is simple to do this is just to count the tops of the pointy things. So I've got 1, 2, 3, 4, 5, 6, 7 pointy things here. And then what I do is I multiply that by 10, and that gives me my rate. So if I have 7 pointy things times it by 10, my rate is 70. So let's get some practice with this. And just, so for our exams, like you should assume all strips are 6-second strips. So this is my little follow along packet. So we're going to get some practice counting the rate. So let's look at this. So we count our pointy things, 1, 2, 3, 4, 5. So then I times that by 10. So I have a rate of 50. You got it. So let's look at this next one. Let's see, 1, 2, 3, and I guess I could do my pointer thing, that might help. Let me do that. Let's see. Draw. Yeah, that's it. I'm gonna take this back one. All right, so let's see. So we got 1, 2, 3, 4, 5, 6. This takes a lot longer than I thought it would. 7, 8, 9, 10, 11, 12, 13. So I got 13 times that by 10. I've got a rate of 130. I got this last one. We can count it. 1, 2, 3, 4, 5, 6, 7. Oh, that's ugly. 8. So then times it by 10, and I've got a rate of 80. So that is how to count the rate. We'll go to the next one here. So I might stay minimized here, but hopefully for this part, you don't mind if I stay minimized. I know that it looks prettier when it's all up in full screen, but hopefully you can read it fine here. So the next thing after we count what the rate is, we want to see if it's fast or slow. And if we go back to these, we had a slow one. This one had a rate of 50. This one had a rate of 130, and this one had a normal rate of 80. So that's where we start to kind of see, okay, well, is it fast or slow? So the next step, and I'm going to scroll down here to get ready. The next step is to look, is it regular or not? So we need to see if the space between the pointy things is about the same distance. So this is talking about the space here. So this is a regular rhythm, and this is an irregular rhythm, because look at the distance here, how it's kind of long, medium, short, 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 longer, longer, medium, like it's all over the place. So let's get some practice here. Let's attempt to get some practice here. All right. So effectively, we're looking for the distance between these pointy things. Let's see if I can do this. Ugh. Oh, it didn't turn out so bad. So we're looking at the space in between this. So effectively we want to look, and sometimes there might be a little off, but overall, I'm talking about unless there's something like major difference, you don't need to sit there and count all the little minor boxes, but overall look at it. And a way that I tell students to do this, if you're not sure, is you could take your scrap paper and you can mark on one side on one of the pointy things, and then mark to the next one. And then you can carry that paper and see if it marches out. It's hard to show this while I'm on this screen, but hopefully that makes sense. So what do you call it? For this first one, is it regular? Looks like it's about the same distance problem. So this first one is regular. So then we go to this next one. So look at this. So there's some that are like this, and then there's some that are obviously a lot longer. So this is an irregular rhythm. So you can kind of see how it's kind of like about the same, longer. So, they have these, there's definitely an irregularity there. So let's look at this one. Same thing here. I got this long beat here, long distance in between, and then short. I'm sorry, my arrows suck, but this is why I'm not an art teacher. So, but you can see it's kind of short, longer, short, longer. So you can see the difference there. Then we get to this one. Now I know you're gonna say, oh my God, it's upside down. There's something wrong here. It's okay. this patient has something not right going on for sure, but we're not worried about that. All we're looking at this one is it regular? So let's look at this one. Regular, 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 regular. So you see it has the same distance. So this one is a regular rhythm. So that's our second step. So we've determined what the rate is it fast or slow? Then we've determined is it regular and what do you call it, or not. And then we are going to go to, can we see regular P waves? When we say regular P waves, if you're ever questioning and saying like, is this a real P wave or is this a P wave? It's not a P wave. You should never have to question it. It should be very easy to tell that hey, this is a P wave. You see like a squiggly line, that's not a P wave. So in real life, there's lots of artifact, but in nursing school world, everything is perfect. So for this first one, do you see a normal P wave? Well, heck yes, I do. Look at this. Look at that. Look at that beautiful hill right there. Beautiful P waves. Don't mind my weird skills here, but there's a P wave before all of that. And look at this one. Pretty cool. So yeah, nice and beautiful P waves. I can tell them. So now we'll get to this one. Whoa, what's going on here? Now, some of y'all might be like, oh, that's a P wave. No, it's not. It's just a big old squiggly line. So this is all squiggly. So if you cannot see a discernible P wave and then the QRS, like a very simple, this is not a normal P wave at all. Let's look at this next one. So then with this one too, see how it's kind of just a squiggly line right here? There is no discernible P wave. It's just like a wavy line. This is a beautiful atrial fibrillation, but this is not. I'm gonna put a question mark here, like. Okay, yeah, I make a lot of sound effects, and I'm sorry for that. So this is not a normal rhythm at all. So let's go back to my PowerPoint. So we've counted the rate. We've seen if it's regular. We looked at our P waves. So now we're going to look at our QRS. So when I said if it's skinny or fat, that was that 0.12, the 0.12 that we want to be less than. You might be thinking, oh my God, how am I going to tell? I'm going to have to measure it out. You do not have to measure it out. When we give you a rhythm, it's going to be very straightforward, like very obvious. So you can see here, this is a skinny QRS and this is a fat one. Look at the difference there. It's very obvious. So you want to, if I have a top of the heart problem or an atrial problem or an atrial rhythm, you only have to know about 3 atrial rhythms. Then I'm going to look for, I should have a skinny QRS. If I'm having a bottom of the heart problem, which really is only 2 rhythms, then I'm going to have a fat QRS and see how fat and wide that is. And there's definitely something not right. So let's look at these. So for this first one, you may say like, oh, let me count the boxes, but overall, is this skinny? So we're looking at this and we're looking at this distance right here. I'm going to try to make a little line like this little distance right there. That's not what I was hoping for. All right, sorry, I panic sometimes. No, and overly panic. Oh, what just happened? Jesus. All right, yeah, this is why I don't do a lot of things that require life skills. So there, let's see if I can do it now. All right. I have no life skills. All right. So we're looking at that little, we're looking at that QRS and seeing the width there. Is it skinny or fat? So we got a skinny one. Look at this one, super skinny. Look at this skinny little QRS. What do you call it? No, oh my goodness, look at this one. So this is very obviously wide. Look at the distance here. We're looking at this distance here, but look at this very wide distance. You can't even see any P waves or anything else. It's just this wide, like, oh, that's horrible, but you get the point. All right, I'm gonna stop doing this to myself. So needless to say, you can see it's nice and wide and fat. We go to this one. Look at this one. This is super skinny. So you're looking at this one. Look at this. It's super skinny. So they have very skinny QRS, it's skinny and fast, where this one is fast and wide. And this one, Lord knows what's going on, but I can't even tell what's going on. So I'm going to say this is wide. Like there's nothing discernible there. Sorry. So maybe this was all just a bunch of garbage to you, but hopefully it brought some stuff together. So let's bring it all together now. So let's go back. Actually, I'm gonna go back here. So let's bring it together and be systematic. So first, let me do this here and let me take this off. Stop you. Cut it out. Let's see if I can cut this up. How do I get it? I want to do this. Okay, yeah. Alrighty, so what is my rate here? Let's count. So we always start with the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. I am 17 times 10, which is 170. Is my rhythm regular? No, it's irregular. Because you look at the distance in between all of these. And is there a regular P wave? No regular P waves. Is my QRS skinny or fat? It looks pretty skinny, so I'm gonna say skinny. So from this information, just looking at this, I have a fast, skinny rhythm that's irregular with no regular P waves. You might already know what this is. If you do, you're my best friend, and let's just run away together. I'm ready. So I love EKG, and we can talk anytime. I'm down. All right, I'm gonna stop. So effectively, what you want to look at here is if I know it's skinny, then I know that it has to be a top of the heart problem. So, and I only have 3 top of the heart problem rhythms. I have atrial fibrillation, atrial flutter, and supraventricular tachycardia. Now, there's a lot more rhythms than that, but I'm talking about the ones you need to know. And so the difference there is I have AFib and aflutter, which are irregular, and then I have SVT or supraventricular tachycardia that is regular, fast, and skinny. So if I got something fast but irregular and it's a top of the heart problem, my only choices are AFib or aflutter. And then to differentiate those two, and I promise on the exam, we're not going to give you one that's like, is this AFib or aflutter? Because really, it doesn't matter. We treat it the same. Like, yes and no. It really depends on how the patient is. But like, it's not like, oh my God, this is AFib versus aflutter. And like, it's good to know and be able to tell that difference. But just know that 9 times out of 10, it's AFib because it's much, much more common. But you can see here, they have this very like fibrillatory or scratchy appearance. So this is atrial fibrillation. If you didn't know this and you're still lost, don't worry. We haven't actually gone over these rhythms yet, but I just want to teach you the systematic method first, and then we will go into the rhythms themselves. So let's look at this next one. So what is my rate? 1, 2, 3, 4, 5, 6, 7. So it's 7 times 10 is 70 beats per minute. Is it regular? Yeah, it looks pretty regular. Is there QRS or P before every QRS? Yes. Looks pretty regular. Is it skinny or fat? It looks pretty skinny. So I have what looks like a pretty normal rhythm. There's a P wave, a QRS, and a T wave. I have all my parts. I have a P wave, QRS, and a T wave. My QRS is skinny, which is what I want it to be, so I don't have a ventricular rhythm. My rate is normal. It's not too slow, not too fast. So what I have here is normal sinus rhythm. If everything's normal, rate's normal, and I have all my parts, then I have normal sinus rhythm. Let's look at this one. So we've got a rate 1, 2, 3 times 10 is 30 beats per minute. So a little slow. Is the rhythm regular? Let's look. Yeah, looks like there's the same amount of space between each. Yes. And is there a P wave before every QRS? Absolutely. Yes. So, and then we want to look at, is my QRS skinny or fat? It looks nice and skinny. So I've got a seemingly normal rhythm. It's a regular rhythm. There's P wave, QRS, and a T wave. Everything's normal except it's a little slow. If everything's normal, but it's a little slow, we've got sinus bradycardia. Woohoo! About to get into that too. Is this my last one? Okay, cool. It's after this. Okay, yeah, cool. I got it. So we've got a rhythm that looks kind of fast. Let's see. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So 20 times 10, that is a rate of 200 beautiful beats per minute. That poor heart. And so is it regular? Looks pretty regular to me. Is there a P wave before every QRS? Now, you guys are probably going to say no. There is kind of a little PEC's little notch here that is a P wave there, but like I can't really tell. So like it's going too fast. So I'm going to say yes and question mark. So don't worry, it won't matter for this one. And then it's skinny. So I got a skinny rhythm. So I have a top of the heart problem. So I have a top of the heart problem. So then I have to see, is it regular or not? Because remember, if I'm irregular, I'm atrial fib or atrial flutter. If I'm regular, then I have, the only option I have is SVT or supraventricular tachycardia. So if I'm skinny, fast, and regular, I have to be Supraventricular tachycardia. Beautiful, beautiful. All right, let's get back into this before you guys are probably have already turned this off by now and are running far, far away. But anyway, let's jump back in and start going into these rhythms. So what are some, let me move my face over. What are some common reasons that I would have a dysrhythmia? So there's a lot of reasons, and I would not spend all your time making flashcards over these reasons. I would look at these reasons and kind of understand that there's a lot of stuff that can lead to dysrhythmias. Heart disease, like any sort of cardiovascular disease, like hypertension, heart failure, et cetera, can lead to dysrhythmias. Acid-base imbalances can put you at risk for dysrhythmias. Any sort of drug or alcohol abuse, use, et cetera, can put you at risk. Caffeine. So nursing students are really high risk for dysrhythmias because they have a lot of side effects like stress and alcohol and caffeine. So yes, medication side effects, it can cause dysrhythmias. Electrolyte imbalances are a big one. Lack of oxygen. So when you have decreased oxygen, it can definitely throw you into, your heart needs oxygen to survive. So it definitely throws you into abnormal patterns, and then infection as well. So we always have to start before we get into like some of the other abnormal rhythms about talking about what's normal. So you can see well, the first one has normal in it, which makes it so nice. But all of these have in common is that they have sinus in them. And so sinus means that it's originating from my SA node, or the node at the top of my heart that's like my main node. That's the one that I want everything to be originating from. So if it's originating from my sinus node, I'm okay. Like these rhythms generally okay. They're going to need some treatments, which we'll talk about for sometimes if they're symptomatic, but generally like my goal in dysrhythmias is to get back to sinus. I want sinus rhythm in some way, normal sinus, sinus bradycardia, sinus tach. Prefer normal sinus rhythm, of course. So normal sinus rhythm, here's a strip of it. What does it look like? It has a P wave, a QRS, and a T wave. So it has all the parts that it needs. It looks so beautiful, doesn't it? The rate is going to be from 60 to 100 beats per minute. My R to R interval is going to be, and so that's like a normal heart rate. My R to R interval, or that space in between the QRSs here, it's going to be normal or regular. And so what do we do about this? I have all of my components. I have a normal rate. I am regular. So what do I need to do? Nothing. This is normal. So as long as we have kind of all these components in this normal rate and regularity, we have normal sinus rhythm. So I have here on this like document, we're not going to go over it for everyone, but I just want you to kind of see some of the things I have students kind of looking at. So you might want to take notes, and this is on my Google Drive, this form, by the way, if you wanted to use this actual form, but you want to see, what does it look like? You want to see, is it dangerous or life-threatening? Yes or no. For normal sinus rhythm, it should be a big no. And then what treatments will I need? And for this one, there's no treatments, or but for others, we're going to have other treatments and goals for the rhythm. So I kind of break these down, when we go through the slideshow. So I'm not going to stop and pause for all of these because I already have them on the slideshow, but this is things you should be asking yourself about these rhythms. Or if you're making flashcards, you should make flashcards with a strip on them, and then really be breaking down what's different about it for you, or how are you going to remember it? Is it dangerous or life-threatening? And sometimes it's going to be yes and no. Like sometimes it is, sometimes it isn't. We don't go deep into medications at this level. You do that more at the complex level. But you're going to need to know some general treatments, or what's the overall goal? What are we trying to achieve for this patient? So let's get in and get back in here. Okay. So let's talk now about sinus. Did I skip anything? Okay, sinus bradycardia. So this one we looked at a little while ago on that other strip. So they have a P wave, a QRS, and a T wave. So they have all the beautiful parts that I need to make a rhythm. It has a normal R to R, or distance between my QRS complexes. But the only thing that's abnormal in this rhythm, because it's normal, except it's a little slow. So remember, my normal heart rate is 60 to 100. So if I'm getting less than 60, I'm starting to get into sinus bradycardia. In order to have sinus, I have to have a P wave, QRS, and a T. So anytime if there's not a P wave there, if the P wave is upside down or something else is going on, which you'll learn about in complex, that is not sinus, because there is not all of the components. So to have a sinus rhythm, P wave, QRS, and T wave. I'm not saying just because you have all three of those, it's definitely sinus, but in order to qualify for having sinus bradycardia, you definitely have to have all three of those. So this can be completely normal. In athletes that are really in shape, that are very adjusted to having a low heart rate, they can do that. Or when we're sleeping, our heart rate's lower. If you guys wear those, Apple Watches or Fitbits and track your sleep, you may see that your heart rate is lower as you're sleeping overnight. It can be also, it's expected with medications like beta blockers and digoxin for the heart rate to decrease, but it shouldn't go down too low. Like, so if I have a patient that's bradycardic, remember, I'm not going to give this medication if it's less than 60. So I'm expecting the heart rate to maybe decrease, but my goal is not to get bradycardia. So this is something that students find very confusing. My goal with beta blockers and digoxin is not to have bradycardia. It's to have a normal heart rate. So I definitely want to keep an eye on it, because a lot of times what these medications can do is put me in a lower rhythm. And sometimes it's okay, sometimes it's not. So you always have to look at the patient's stability when it comes to sinus rhythms that are like sinus bradycardia or sinus tachycardia. How are they tolerating it? Because maybe their heart rate's 57, their blood pressure's fine, they're doing just all right. Maybe their heart rate is 52 and they're not doing so hot. Their blood pressure's low, they're diaphoretic, feeling a little dizzy. So we'll talk about this later, but with all rhythms, especially ones like this that can be stable or can be unstable, you always want to look at how's the patient doing? How are they feeling? Do they have any symptoms? What's their blood pressure? How are they oxygenating? What's their SpO2? So my overall goal for this patient is going to be to speed up their rhythm if it's symptomatic. And the ways I can do it, there's medications that we can use. And again, you don't have to know these, but just so you kind of have heard this at some point before you go out there into the beautiful world of nursing. Atropine is a common medication used. And then if we need like a continuous infusion, we'll use things like dopamine. And you'll talk about dopamine in complex a lot, because we use it for a lot of slow rhythms. But very commonly, especially if it's something long-term, because a lot of people with bradycardia that it's symptomatic, they may have a congenital issue or they may have something else going on. They do need either temporary or permanent pacemaker placement, which we're about to talk about. So a pacemaker is a device. It is an electronic device. And effectively, remember how I said that, a sinus rhythm comes from the SA node. That is my pacemaker of my heart. That is my, main, I don't know why I want to call it a bro. I don't know why that just came into my head, but my head's a very strange place. But I was going to say big kahuna is probably a better way to say it. Like, so my SA node is the big kahuna on campus that is taking care of my heart, making sure that it's pacing the way it's supposed to. So if my SA node's not working, if there's something going on, my heart rate's slower than what I want it to be, then a lot of times I need to use a pacemaker. In other words, I need a device to take over that role of pacing my heart so I can make sure that I am going fast enough. Because just to kind of bring you back, what's the big deal with a slow heart rate is that if my heart rate's too slow, I'm not going to get enough cardiac output, because I'm not having enough beats per minute in order to really, truly ensure that I am I'm getting enough volume out. So, your heart needs to beat at least so fast every minute in order to get that good cardiac output. So usually with pacemakers, we use them to speed things up. The pacemakers are not usually, they can on some occasions be used to slow down fast rhythms, but 99.9999% of the time we use pacemakers for slow rhythms. And in nursing school, you should always think pacemaker, slow rhythm. So pretty much what we do is we set a rate on this pacemaker, and it forces the heart to beat at least so many beats per minute, whatever we set it to. And generally we're going to set it to something normal. So like, what's normal? 60 to 100. So sometimes we can set it at 60, but 9 times out of 10 we set it at 70 or 80, because we want the heart rate up a little bit more in that normal range. There's a variety of types of pacemakers. I have pictures on the next slide. So there's what's called a transcutaneous pacemaker. There's transvenous, and I'll talk about each of these as I show you the pictures. It'll be easier as I'm doing. There's epicardial. Those are all temporary pacemakers. And then there's permanent ones, like a permanent pacemaker that's implantable, an ICD, which is an implantable cardioverter defibrillator, and then a biventricular pacemaker, which we use in heart failure. So let's look here. So we have down here in the center, we have what's called a transcutaneous pacer. And this is like for emergencies. You can do it with a crash cart. Effectively, you put the pads on the patient and it gives them, a shock on their skin to get them paced. It's not, I don't want to say it's like a shock, but it feels like a shock to them for sure. So most of the time, if we're going to transcutaneously pace, we want to sedate these patients. It's just so mean to not sedate them because it's painful. So we definitely want to help them out there. Now, some of these patients are not going to be with it. They may have recently, had their heart stop or something, but keep in mind, generally we sedate patients if we're going to transcutaneously pace them. This is all temporary. We also have what's known as a transvenous, which is another temporary. So they can go to cath lab and have a internal, kind of like it's a temporary through the vein, and through a central vein, you can see here into the heart, pacemaker. And so this helps like for patients that maybe like they're in cardiogenic shock or have something really serious going on that they're going to need a pacemaker, but they're not stable enough to go get one. So we'll put this in temporarily. There's also this one up here, which is what are known as epicardial, which is on the outside of the heart's pacemaker. So this is usually done after cardiac surgery, like a CABG or a coronary artery bypass graft, which you'll learn about in complex, which is where we sometimes, after that surgery, they can be unstable. So we keep these pacing wires on them for a few days to make sure that if they need emergent pacing, that we're right there on the heart. Then we have our permanent pacemakers. So there is, this looks like that one looks very complex. So I was trying to see which one of these, it could be either or. I'm not a lead in sinus. So yeah, because one of these is because this one looks more fancy. So this looks like this would be the, what do you call it? It's what's called a biventricular pacer. Yeah. Interesting. So yeah, so I want to say that this is the biventricular pacer, but again, you're not going to be given a picture and expect to know. But here, let me just stop trying to make it complicated and just keep it simple. So you can either, have a pacemaker that goes into the heart and just helps to pace either the top of the heart, the bottom of the heart, just depending on kind of what's needed. And it's what's known as a permanent pacer. You can also have what's called a biventricular pacer, which I believe is this one, but these look so similar. Maybe I just have two pictures of the same thing. So, but the whole point here is with the biventricular pacer, it's used for heart failure because sometimes the ventricles get out of sync. So it helps the ventricles to sync together. And then you have up here what's called an ICD or implantable cardioverter defibrillator. So this is for patients that maybe need to be paced, but also are at risk for like their heart stopping, sudden cardiac death. So it kind of forces them to, it helps to monitor their heart rhythm. And if they go into like ventricular fibrillation, ventricular tachycardia, it actually shocks them. So yes. So much fun. So what teaching do we want to give about these? So overall, like the basic teaching, there's a whole lot of stuff in your book, but here's the takeaways. One, I just want to kind of leave this out here because there's a lot of misconceptions. Yes, you can use a microwave with your pacemaker and ICD. What do you call it? They are microwave safe. Now, when it comes to MRIs, it's touch and go. In real life today, most of them are MRI safe. But what we have to do is we usually have to follow a protocol. We have to call the company, verify it, etc. But because nursing school is so many years behind, generally what we say is that, they're not like, don't use them in MRIs. But it just depends. We're always going to have to get them looked into. Anytime anyone has anything in their body, we always have to have it looked into to make sure that it's not going to lead them. Because with an MRI machine, you have to remember that we'll suck them in and magnetize them. We don't want that. So other teaching that we want to give for pacemakers is we want to make sure that they avoid any lifting or trauma to that affected shoulder, because pretty much what happens, it's usually up in this upper left chest, and it can definitely mess with the nerve. So we don't want them to do any grabbing, pushing, lifting. A lot of times we keep their arm in a sling post-operatively. We don't want them to be doing anything with that shoulder. They also need to know how to monitor their pulse, because just because they have this device doesn't mean it's always going to work. So they need to know what it feels like when their pulse drops and how to check their pulse regularly. We also usually don't want to get it wet for a little bit, like submerged in water, like the incision and stuff early on, but shortly after they can go and, get in the water and stuff like that. ICD wise, we want to teach them like, it's going to be a lot of the same stuff, but the stuff that the teaching that's special for ICD is going to be if it fires, we want to make sure to tell them to call their doctor immediately and go and get help. Because it's kind of like, think of it like, hey, let's say that I was diabetic, my blood sugar dropped. I still need to report that to my doctor, because even if, let's say that I treated it and I'm better now, we need to figure out what happened. So same with the ICD. Especially if it's starting to fire, then usually it's a sign that there's something that's not right. So usually they need to come in and have it, have their heart checked out and make sure that there's not something new or different going on. This just kind of gives you an image. You're not going to be tested over like looking at a paced rhythm, but I want you to know what it looks like on a strip. So a paced rhythm, it has like these little spikes before wherever it's pacing. So if I have an atrial or top of the heart pacer, you see this little spike before my P wave, it's saying that my P wave is being paced. Then on this one, you can see there's a spike before my QRS, and you can notice it's a little bit wide. Keep in mind that with a paced rhythm, it's always going to show up wider than a regular rhythm is. So that's expected. So, but I have this pacer spike, and then I have this QRS, which is showing my bottom of my heart is being paced. I also can pace both chambers. So you see there's a spike before the P wave and a spike for the QRS. So this is an AV paced patient. All right, so that was sinus bradycardia. When, like I said, the problem there is the low cardiac output. So if people are symptomatic. Now, if they're okay, we would just kind of watch it, monitor it, but we definitely want to make sure they're getting enough cardiac output and getting enough flow. So then on the opposite end of the spectrum, we have another sinus rhythm that's known as sinus tachycardia. So this is the opposite end of the spectrum where I have all my parts. I got a P wave, I got a QRS, I got a T wave. So I'm sinus. I'm normal when it comes to my regularity. I have a regular interval. But the only thing that's different is my rate's greater than 100. And usually the rate here is going to be like 100 to 150. So just like with sinus bradycardia, there are normal causes. So like having exercise, pain, or stress, it's normal for my heart rate to increase during those times. But there's also some pathological causes or causes that usually, and I mean, sometimes we have to intervene with the others as well. You know, some of the more pathological causes, if I'm not getting enough oxygen, if I'm, if I have a fever, my heart rate goes up. If I'm dehydrated or I don't have enough fluid in my body, then I'm going to usually have an increased heart rate. So the treatment here for sinus tachycardia is going to be really important to get to the bottom of the cause, because I can give medications all day long to lower my heart rate. There's lots of great medications. I love beta blockers, but here's the thing is if underlying my heart rate's high because I don't have enough oxygen, because I have a fever, because I'm in pain, like no amount of giving beta blockers is just masking or covering what the underlying problem is. I always need to get to the bottom of the problem. So if my problem is I'm dehydrated, I need fluids. If my problem is that I don't have enough oxygen, I need oxygen. If my problem is I have a fever, I need to treat that, treat that fever with antipyretics. If I have pain, I need to treat that. If I'm exercising and I'm just getting too stressed out, I need to rest. So there's all these things. We always want to get to the bottom of the cause first. Now, if I do all that and I've treated every possible thing that's coming up and I'm still elevated, that's when then I'll want to go to medications. And like I said, usually the number one we will use is beta blockers. So those are our sinus rhythms. Now let's get into our other rhythms. So let's talk about what happens when there's a problem at the top of your heart. So if you have an atrial problem or a top of the heart problem, there's going to be a problem with your P wave. Because remember, this is why, like, you know, if you're finally like, why did this lady go into all this crazy stuff? And why didn't she just go into these rhythms? You have to kind of have a little context, and you have to realize that the P wave is a visualization of what's going on in the top of the heart. So if there's something going on with the top of the heart, there's something weird going on with my P wave. It's either going to be missing, hidden, like we talked about in that one rhythm where it was hidden in the strip. My QRS is going to be normal and skinny because there's nothing going on. Remember, QRS is the bottom of my heart. If I have a top of the heart problem, my bottom of my heart or my QRS is going to look normal. And so like I said, there's 3 atrial rhythms that we're going to be covering this semester: atrial fibrillation, atrial flutter, and then supraventricular tachycardia, or SVT. So let's talk about AFib. Now, this is going to be one of the most common rhythms you see in practice. And I always tell students, if you learn any rhythm, this is the one you want to learn. You're going to see it a lot. You're going to get tested over it a lot. It's everywhere. What's happening in atrial fibrillation is the top of the heart is not fully contracting, it's fibrillating. So usually there's this really nice opening and closing action that that the valves are doing and things like that. But what's happening, I want to say the valves, but the top of the heart has this really nice contraction. But what happens in atrial fibrillation is what's actually happening at the top of the heart is it's just fibrillating. It's just randomly kind of going like this. So some blood is moving forward, but it's not moving forward. It's not getting that really strong contraction, that opening and closing. So we're just kind of randomly fibrillating and draining into the ventricle. So I'm going to be worried about a few things here. So of course, if I'm not getting a good contraction, I'm not going to be getting as much blood moving forward. So I can have what's known as decreased cardiac output. which can lead to hypotension. I can talk hypotension or low blood pressure. Because the other thing that's lost is normally the top of the heart is so sweet, like it wants to help out the bottom of the heart. So what it does is it pushes some blood forward, and then at the end, it's like, hey, buddy, I'm gonna give you a little more. And it has this extra thing called an atrial kick, that it pushes a little bit more blood at the end of that contraction. But when I'm having this fibrillatory activity at the top of my heart, it's not happening. I'm not getting that extra blood flow. The other problem is because I'm not moving blood forward, it's just chilling in one space. And anytime you think pooling of blood or hear about pooling of blood, you should think blood clots. So these patients are super high risk for blood clots. And I'm really going to be concerned about this, because not only are they pooling blood, but where is the blood pooling? In the atria. And if that clot, let's say they have a clot that forms in there, where is it going to go? If it's on the right side of my heart, it's going to go to my right ventricle and then into my lungs. If it's on the left side of my heart, it's going to go into my left ventricle and then somewhere in my body. It can cause a heart attack, stroke, blood clot. I already said heart attack, because that's the most important thing in my life. But yes, because I love the heart. But anyway, or a blood clot. Yeah, I said stroke, heart attack, or pulmonary embolism. Oh, I already said that. Yeah, anyway. All right, I'm going to stop repeating myself. So pretty much we're going to be worried about a blood clot in the lung, blood clot in the heart, blood clot in the brain, or blood clot in the leg. And so like they can cause very serious blockages or death. So we're worried about not enough volume, flow, or pressure moving blood forward. And then we're also worried about the stasis that can lead to blood clots. So in this rhythm, like we were talking about earlier, the P waves are going to be non-discernible. I can't even tell that there's a P wave here. It's going to just look like a squiggly line. The QRS is regular and skinny, and my R to R is going to be irregular. So this one, a lot of times with atrial fibrillation, the way that a lot of people remember is that it's regularly irregular. In other words, I can always count on it being irregular. Like it's the rate in between is always going to be off. And when you're looking at it on a monitor, the heart rate will be jumping around. It'll be like 73, 84, 62. Like it's going to be jumping all over the place. So you're going to be like, oh, and a lot of times if you feel their radial pulse or listen to their apical pulse, it's going to be irregular. Atrial fib can be slow or fast, or it can be a normal rate. So it could have a slow rate, what we call slow AFib, could have a rate 60 to 100, which is what we're hoping for. And then also can be what's called AFib RVR, or rapid ventricular rate, where it has a rate greater than 100. And that's where we're going to be more worried, because this rhythm's already dangerous as it is, but the faster that it's beating, the more dangerous it's going to be. In other words, the faster that I'm top of my heart's fibrillating, the worst possible, the higher the chance that they're going to have lower blood pressure, and then also the higher chance they're going to throw a clot. So we definitely want to avoid those really fast rates, because what's happening when it says rapid ventricular rate is usually what is going on is that they go into this abnormal fibrillatory rate, and then the body's like, hey, I'm not getting enough blood pressure. So the sympathetic nervous system gets activated, and then my ventricular rate increases in response to the sympathetic nervous system getting activated. So I have this really fast, irregular rhythm that can lead to a lot of really serious problems. So we also have a flutter. And like I said, we're not going to really expect you to sit there and you have to differentiate both, because at the end of the day, some of these are a little bit trickier, but excuse me, let me get some water. What we want to keep in mind is that, this is the same thing as AFib. We treat it effectively the same. The only difference is in the waves. So here, these are what are called sawtooth waves. So you see how they're a little bit more organized. So I'm going to show you like a side-by-side here coming up, but they're much more organized. So when you're looking at these, you're just going to be looking for something that's a little bit more like the other one, it looks more like a squiggly line. These are much more discernible, but at the end of the day, it's the same problem. They still have the loss of atrial kick, hypotension risk. They still are pulling blood, so they're at risk for blood clots. They still can be slow or fast. The only other difference is sometimes with this one, it's a little bit more regular. So sometimes you can see here, like this is a normal R to R. So it's got this weird extra P waves that are these sawtooth, they're kind of like V-like waves, but it's regular. So these are what are called F or flutter waves. So sometimes it's a little bit more predictable. So there are times that a flutter can be a little bit more stable than AFib, but you don't need to know that, and every patient's different. So don't try to create any rules, because nursing is full of gray, like I mentioned. So I said the treatment's the same. So how are we going to treat it? So there's two parts to AFib and A-flutter treatment. First, we have to treat the rhythm. So we're going to give medications that either convert or slow it down. And again, I'm not going to go in depth in these, but you're going to hear about some of these. So there's calcium channel blockers like cardizem or diltiazem. We can use medications that are sodium channel blockers like amiodarone. And then we also can use things like digoxin. It's not used as much because it's so toxic, but we can use that to help slow things down. But all of those three that I just mentioned, they not only slow it down, but they convert it. So because really the goal for AFib is to convert it back to a normal rhythm. That's the overall what we're hoping for. Now, if we can't do it, or if they're super unstable, they got a really fast rate, we're going to do what's called cardioversion. I haven't talked about cardioversion yet, but I'll get into it. But it's pretty much a shock that we give while a patient still has a pulse, but an unstable fast rhythm. So that's great. So let's say that we treat this rhythm, regardless of the outcome. These patients are usually, because like most of the time people are in and out of it for their whole life, very prone to it. Most of these patients are going to be on anticoagulation the rest of their life. And that's because they're so high risk for clots. So generally we do not put people on anticoagulation lightly, but the one person we do not hesitate to put on anticoagulation is those with AFib and A-flutter, because they are so high risk for blood clots. So effectively medications to convert, slow it down, electrical, shocking if we need to, called cardioversion because they have a pulse, or I always like to think cardioversion conversion, we use that if they're unstable, and then anticoagulation for life. There's other therapies we can use to support them, like bed rest, oxygen. They may need some fluids and stuff like that if they're hypotensive, but those are just general supportive treatments versus like the very specific ones, because we're going to do that for just about all of them. Because I haven't really mentioned this, and you might notice that I'm not putting what are the signs and symptoms of these dysrhythmias, because effectively for dysrhythmias, all the signs and symptoms are the same. They all like have very, very similar things going on here. So they usually feel syncope or lightheadedness. They feel dizzy. They can be short of breath. They can have decreased blood pressure, stuff like that. And like all this is all about perfusion, because when it comes down to it, the reason I'm making you go through this long, painful lecture is because dysrhythmias lead to problems of perfusion. And we have problems in perfusion, we're worried about our organs and tissues failing, etc. So let's keep going. So here's that side by side, like I mentioned. Here's atrial fibrillation. You can see those fibrillatory waves, and we have flutter. And so you see the difference. These are kind of squiggly, whereas this one is that beautiful sawtooth pattern. Woohoo, so pretty. So let's see if I want to say anything else there. So yeah, so they're different in the look, but again, we're not really trying to test you on the difference here because the treatment's the same. But just know there is a difference there. So let's talk about our other atrial rhythms. We also have what's known as supraventricular tachycardia, or SVT. So a lot of people find this confusing because it has ventricular in it, but you have to know what supra means, and supra means above. So this is above the ventricle tachycardia. So this is a rhythm that is fast and skinny. What do you call them? That's a good way to remember it, because a lot of our rhythms that we're going to be getting into next, the ventricular ones, are going to be fast and fat. So we have a fast and skinny rhythm. Now, remember I said sinus tachycardia kind of goes from 100 to 150. This one usually is above 150. I'm going to be most concerned for this patient about what their blood pressure is, because a lot of patients can go into this rhythm and some people know it and some people don't. I talk all the time about patients that they're in a crazy rhythm. I go in the room and they're eating a peanut butter sandwich and saying like, hey, what's the problem? And sometimes I tell them, hey, you're having an irregular rhythm. We need to treat this. And they're like, can I finish my sandwich first? And I'm like, hey, bro, like, we really want to get to the bottom of this. And so we always want to see, if they're stable or not, but we're not going to sit there and let them finish that sandwich. Usually we want to get to the bottom and treat it. We want to see what symptoms they're experiencing, how they're feeling with it. Now, with this rhythm, we're not going to just watch it. If they're like, hey, I feel great. Oh, their blood pressure is good. I'm not going to just be like, it's okay. Because eventually their heart's going to tucker out when it's going this fast. But we do want to see kind of where they're at, how unstable they are, because that's going to help guide treatment. Now, you're not going to be given a problem where we give you like a blood pressure and you're going to have to decide like, oh my goodness, well, here's the dose of medication that we're going to have to give or whatever. But you should know, generally if they're unstable, we're going to go to more invasive treatments first, versus if they're stable, we're going to start with least invasive first. which I'll talk about here in a second. So supraventricular tachycardia is actually really common in young people and very common in students, because students do a lot of the risk factors, which is don't get enough sleep, stress out a ton, drink too much caffeine, things like that. This is very common. So be watching out for you and your friends. So the goal overall for supraventricular tachycardia treatment is going to be to convert it and slow it down, just like with AFib, like we talked about. So my goal is to get it back to a normal rhythm or like a sinus. And then of course, if nothing else, I want it slower because it's going way too fast. So there's three main treatments for supraventricular tachycardia. First, what I can do is what's called a vagal maneuver. And this can be done a variety of ways. There's a ton of different ways. We can tell the patient just to do a really forceful cough. We can have them bear down and tell them, act like you're having a bowel movement. Now tell them not to actually have a bowel movement, but just to pretend like they're having a bowel movement. And then we can also have them blow into a straw. There's a lot of ways, but we're trying to get them to get pressure in their intra-abdominal area, which creates, puts pressure on their baroreceptors, activates or stimulates their baroreceptors, which causes the heart rate to go down. So sometimes, in other words, they can literally self-pressure themselves back into a normal rhythm. This could be as simple as like they can hold their nose and make a lot of pressure, like hold their breath and like bear down and push really hard. And sometimes that can convert them back to a normal rhythm. Medications that can be given. You'll learn about this later. Like I said, we don't test you on this, but adenosine or adenosine, however you want to say it, is a medication that's given. And this is a medication that's pretty fun to learn about. I don't mean it's actually fun to do this because that sounds really dark and creepy, but it's fun to learn about because what it does is it actually is like if you had like on your computer when it's not working, or any device that's electron that's not working, you're like, let me turn it off and turn it back on and see if it starts working. Well, that's what this medicine is. Like literally, it's the only I don't want to say that, it's one of the few medications that we give fast, rapid IV push. We usually give it over a couple seconds and then slam a flush in after it. And what it does is it causes the heart to stop. If it works right, it causes the heart to stop. And then we are just praying to God that heart restarts. So we got the crash cart, doctor, everybody ready. So that is, that's what, oh, excuse me, I'm dying. Excuse me. So that's what adenosine does, helps to restart the heart. And then we're hoping that when it restarts, it will be a normal rhythm. And then the most invasive thing we can do is cardioversion, or shocking them back. So again, we shock people with a pulse that is a fast, unstable rhythm. But you can kind of see the progression here. I can try least invasive, no actually, like just telling them, hey, bear down, create this pressure here in order to convert back to a normal rhythm. We can try medications in order to get them back to a normal rhythm if those don't work. And then we can go to the electrical options. All right, so those are the top of the heart problems. Now let's go into the bottom of the heart problems. And so these are usually more serious because the ventricles are your powerhouses. In other words, your ventricles are, like I was talking about before, they're the ones that pump blood to the most important areas. And we're really needing that super good contraction. So we're kind of getting like atrial rhythms, like AFib, A-flutter, SVT. They definitely can cause problems. They can be unstable. But these ventricular problems, we're sometimes wondering, is the patient still alive? So there's a difference between unstable and then are you dead or you're not. Like we talked about there, if you have a P wave problem, you have a top of the heart problem. If you have a ventricle problem, you have a QRS problem. So there's something going to be off with my QRS when you're looking at this EKG strip. You may or may not be able to see a P wave because a lot of times once I'm getting in ventricular rhythms, top of the heart's like, it doesn't matter what it's doing, the bottom of the heart's not functioning. Usually your QRS is going to be wide and bizarre. You might see like, oh, that's a really weird QRS. And the two rhythms you need to know, and ventricular tachycardia has kind of like two, subclasses, but it's one rhythm. There's VTach with a pulse, without a pulse, and then there's VFib. And so that's what we're going to talk about. So ventricular tachycardia with a pulse or without a pulse, it's going to be fast and fat. That's how we usually remember it. P waves may or may not be seen. The QRS is wide and bizarre. It kind of just looks like that V. Your R to R can be regular. Like look in this, like it has a regular R to R here in this one, or it can be irregular. It comes in different shapes and sizes. It doesn't matter if it's regular or not. Really, we're just looking for fast and fat here. you know, the biggest concern I'm going to have here, because like I mentioned, it can have a pulse or no pulse. Is there a pulse with this? So we're always going to look at the rhythm and be like, okay, what's going on here? Do they actually have a pulse with this? And so you can't just go by the electrical activity, et cetera. You always want to check. So like I mentioned, it can come in different shapes and sizes. So it can definitely have this kind of up and like, you know, this is what's called torsades, this letter C, where they can have a very abnormal, it's from a magnesium imbalance. But they can have kind of the strange back and forth. They can have something more regular, something more irregular. So you can see there's a lot of variety here. So how do we treat it? So we treat it differently if it has a pulse or not, because if I have a pulse, I'm going to obviously have a little bit more going for me. So the treatment is very similar in the sense that I want to convert and slow it down with medications, et cetera, because that's the only thing that's really going to help me. But the difference is if I have a pulse, I don't need to restore electrical activity, et cetera, or I don't need to do CPR because I have a pulse. But I'm going to probably need to do cardioversion ASAP, and that's that electrical activity for electrical treatment for patients that have a pulse. So that's kind of like the little mini shock to get them back to normal. So effectively, what my goals here are is to convert it and slow it down. Then if I don't have a pulse, I'm going to start CPR immediately. We're usually going to defibrillate pretty soon in there. We don't want to wait too long to start defibrillation and shock them back into a normal rhythm. And defibrillation is for patients that are in a unstable or lethal rhythm that have no pulse, but electrical activity. And we'll talk about that here soon. And then again, we can use medications to restore circulation. That would be like stuff like epinephrine or to convert the rhythm. And for this rhythm, to convert it, we can use stuff like amiodarone is used sometimes with V-tach and stuff like that. Or like I said, there's a magnesium imbalance. I might do that as well and replace that. All right, so now let's talk about ventricular fibrillation. So this is another fast rhythm, but the difference here is, and like a lot of people say, well, how am I going to tell the difference between V-tach and V-fib? And what I think that the easiest way to do this is really looking at can you really see like those really clear like V's? Like I always think V-tach, like these are very clear and they almost look like they're wide and fat and not pretty, but it looks a lot more organized than V-fib here, where like I can't count a rate here. Like V-tach, a lot of times you can still count a rate and see what's going on. V-fib, it's like I can't count a rate. I don't even know what's going on here. They have fibrillatory QRS complexes. Now you may be wondering what's the big deal here, because I didn't worry that much about AFib. If the top of my heart's fibrillating, I'm still getting some blood forward. If the bottom of my heart is fibrillating, that is not pumping blood forward to my heart and my lungs. So that is zero cardiac output. So something really important to note here, I can have V-tach with the pulse, but I cannot have V-fib with a pulse. There will never be a pulse in a patient with V-fib. My treatment here is going to be to start CPR immediately and then defib for VFib. That's what you're going to hear all the time, that you're going to want to do that. And I'll explain that here in a second. Then we're going to do the same thing like we did for V-tach without a pulse, which we're going to give stuff like epinephrine to restore circulation and then convert it with stuff like amiodarone, et cetera. So there's a lot of confusion, and students are always like, okay, what if I get on a test and like it gives me this rhythm? Do I do CPR first or defib first? So here's what you need to think about this. We definitely want to defibrillate as soon as possible, but my priority treatment is to restore circulation. So I'm not going to sit there in like a patient's in VFib, and I'm not going to be like, oh, wait, they're in VFib. I need to defibrillate them. So I'm going to just wait till the crash cart comes into the room. No, I'm going to start restoring circulation now. So I'm not going to wait for a crash cart to get in the room, get the pads on them, and then defib for them. I'm going to go ahead and start compressions. And then as soon as that defibrillator gets there, I'm going to do it. Because what used to be is that we used to do like one round of CPR and then we would, think about shocking them. Now we want to shock them as soon as possible. So let's say that the scenario, like, so there's kind of two scenarios. Let's say that you're in the room and this patient maybe was fine, and all of a sudden they go into this rhythm. Well, for that, we're going to start CPR, grab the crash cart. Someone else should grab it while you're doing CPR, and then we're going to defib as soon as possible. Let's say it's a different case in that this patient's been going in and out of crazy rhythms. They already have the pads on them. If they already have the pads on them and we're ready to shock, we can shock right away. So it kind of just depends on, do they have pads on them? Are they ready? Because effectively, we want to restore circulation. So if they don't have pads on them, we're going to start CPR because I'm not going to delay CPR waiting for the shock. But I also, once I'm ready and set up to shock, I'm not going to delay waiting to shock them, to finish so many rounds of CPR. Hopefully that makes sense. So VFib can also come in different shapes and sizes, but you just see how irregular it is. It just looks like a squiggly line. So there's also asystole. I know this is not really, I can't really put it under atrial and ventricular. I know I only promised that you only had these like 5 rhythms. There's a couple other little things, but I promise they're not too bad. So there's asystole, and this is where their rate is absent. There is no electrical activity going on here. It's just a flat line. So there might be a little wave to it, but it's nothing like VFib where like, you can see in VFib, there's a very clear like electrical activity. There is no electrical activity happening here. So for this patient, this is what students find confusing is we do not shock for asystole. I know you're going to see it in the TV. They do it all the time. They're like, oh, flat line, grab the crash card. Let's defibrillate them. We don't do that. We start CPR immediately, and then we give medications to restore circulation like epinephrine, and we follow our ACLS protocol. Now, if they eventually get some sort of scratchy electrical activity like VFib, we can shock that. But when they're in asystole, the flat line, I cannot shock this because in order to for defibrillation to work, I have to have some sort of electrical activity to shock. If I have no electrical activity, I have nothing to shock back to normal. So kind of think of it like a dead battery. So what do you call it? Like, like when I say dead battery, like in a car, like if their battery is completely dead, I can't bring it back to life. But if it's got a little bit of a spark left, then I can, get a jump and restart that battery. So there's other minor abnormalities you want to know about, and the main one I'm going to talk about, because there's a variety of things, but the main one I'd want you to know about is what are called PVCs, or premature ventricular contractions. These can be totally normal. You probably had multiple of them since watching this presentation because this is so exciting. But what we start to worry about is when there's more than 3, this can be a sign, this is usually a sign that the patient's going into ventricular tachycardia. So this brings us back. Remember that fun long talk I had about QT interval, and we don't want anything to land on the toilet. This is what lands on the toilet, these PVCs. They're premature contractions where the heart's getting excited. It's trying to flush that toilet early. But here's the thing. You may think like, what's the big deal? It's just an extra beat. One, it's going on during that toilet time, so I can end up going into VTAC. 2, it's not a good full flush. So like it may look like they're having an extra heartbeat here, but usually there's no actual like contraction. There's no actual blood moving forward with this. If it is, it's really minor. So think again, like that toilet flush, like if you flush your toilet, then you wait like 2 seconds and try to flush it again, a little bit might flush, but it's not a full, like, it's not a full, what do you call it? Flushing of whatever you're trying to flush down and getting ready to refill. So we do not want these PVCs, because PVCs are effectively those early toilet flushes we want to avoid. So they can lead to a lot of serious dysrhythmias. And so we can always tell that they're different because they're a wide beat. So look at them compared to the other ones. See how they're wide compared to the other ones? They're not going to look like the other QRSs. A lot of times they're going to be in the opposite direction. Most of the time for these, we're going to just monitor them, but we may need to check their electrolytes, because a lot of times if they're having occasional PVCs are okay, frequent PVCs are not okay, just as a heads up. But yeah, so a lot of times if they're getting frequent, we're going to be worried about their electrolytes or otherwise. So I think I have a thing here. Let's look. So let's see, I went through all these. All right, I think this is my last activity. All right, so can you find the PVC? So where are the PVCs here? Let's go back to my beautiful drawing. So can you tell which ones are the PVCs? Remember, they're always going to be the wide ones. So they're these wide things right here in between these beats, these wide rhythm beats. How about here? Do you see it? Yeah, it's this weird wide beat at the end here. Let's find the PVCs. Oh, look, there's a whole bunch of them here. So this is what's called bigeminy, where it's every other beat. And you can see it's nice, but you can tell that these are different than the other QRs because look, they don't have a P wave before them. They have this weird upside down T wave, and they're wide. And so that's how I tell that they're different from those other beats. Also have this one. These are what are called multifocal PVCs, which some are up and some are down. It doesn't matter which direction they're going. They're wide. They don't have a P wave before them, and they're landed in all the wrong places. Okay, that's it. All right, so I can go back to this full time. Get her going. All right, so PVCs can come in different shapes and sizes. They can come in couples holding hands, so cute. You can have what's called bigeminy, which is where it's every other beat. What do you call it? We can have trigeminy, which is every third beat, or those multifocal, like I said, they're going in different directions. So let's talk about defibrillation and cardioversion. So just to kind of clarify, because I did kind of go over this, but I want to make sure it's clear, is that we only defibrillate or shock patients that have no pulse, but that have electrical activity present. So you have to think about what rhythms this is going to include. So which ones have no pulse? Well, the ones we talked about that have no pulse are VTAC without a pulse and VFib. So those two rhythms, we didn't talk about it, but there's also what's called PEA or pulseless electrical activity, but that does not count here because it's not actual electrical activity. So I'm going to shut up now. Just act like I didn't just say anything because I don't want to confuse you. We do not shock PEA, but yeah, I'll talk about that here in a second. I promise I'll clarify. So yeah, let's just back up and act like I didn't say anything. So there's only two rhythms that have no pulse but electrical activity, and that's going to be VTAC with a pulse and VFib. So that they have no pulse, but there's some sort of electrical activity going on. So for those, I defibrillate. I have something that I can shock, like it's not a completely dead battery. There is still something there that I can shock and hopefully get it back to normal. These patients are not going to have a pulse, so I don't need to sedate them or do anything special. I'm going to try to resuscitate them. So defibrillation is a resuscitation. Cardioversion, think conversion. We cardiovert patients that have a pulse but are in unstable, and it's usually going to be think fast rhythms. We don't cardiovert slow rhythms. We're not going to cardiovert a bradycardia. We're not going to cardiovert heart blocks and junctionals that you're going to learn about later. If it's slow, we pace it, whereas if it's fast, we convert it or cardiovert it. So the rhythms that you're going to talk about for cardioversion are going to be your AFib, a flutter, your SVT, and then your VTAC with a pulse. So they have to have a pulse, but then be fast and unstable. So overall, defibrillate, VTAC without a pulse, and VFib. Then we cardiovert, AFib, a flutter, if it's fast, SVT, and then VTAC with a pulse. So I didn't mention PEA before, and I'm only going to mention this real quick. So PEA is like having asystole. We're going to treat it the same as asystole. We're going to do epinephrine, CPR, etc. But it's called pulseless electrical activity, but it's literally like, it's like your battery's dead, but it's still like there's still a signal on the screen, even though the battery's dead. So PEA, there's not actually, even though the name makes it seem like there's actual electrical activity, you see electrical activity on the screen, but there's not actually any electrical activity happening. So, and the only way we could test you over PEA is we would have to give you a strip that says, like, it might look like normal sinus rhythm, but say there is no pulse. But we usually don't test that heavily on PEA because it's not seen that often. And again, the only way you're going to know is if you check if they have a pulse or not. So if I confused you, just ignore me and keep moving on. I nerd out a little too much. So I talked about defibrillation. There's not a lot that we need to do here because the patient is usually dead and we are trying to resuscitate them. It's an emergency. Like we talked about VFib or VTAC without a pulse. There's zero cardiac output. So we're going to use high energy because we're trying to resuscitate them, bring them back to life. The client's unconsciousness, they're going to be hooked up to the monitor. On the other hand, cardioversion, or like I like to think conversion, this is sometimes an elective procedure where people come into the hospital, they're like, hey, I'm going to have a cardioversion today. They've been maybe in and out of a rhythm or in a rhythm, etc. They're usually going to be sedated for this procedure. They should be because it's painful. So, tell them they're not going to remember it. They may have some burn marks on their skin from the pads and stuff, but they're not going to remember it. And when we do cardioversion, we have to synchronize it. So remember how I said we don't want any beats happening during that toilet time. So pretty much what I do is this machine, the defibrillator machine, it also can convert or cardiovert patients. What we do is we sync it to their heartbeat. So effectively, we make sure that when we're giving them that shock, because they still have a electrical rhythm and they still have a pulse, we don't want to shock them at a random time during their toilet time. So it synchronizes with their regular heart rhythm and make sure that we're shocking them at at a optimum time. And with cardioversion, we use less energy. They have a pulse. We're not trying to bring them back to life. We're just trying to kind of like give them like a boo. like, like, hey, get out of that rhythm. We don't like it. And since it's an elective procedure, usually consent is signed. And again, they're on the EKG monitor. So pretty much cardioversion, less energy. They're going to have, it's going to be synchronized with their heartbeat that they already have, and they're going to be sedated. Whereas defibrillation, they're usually going to be unconscious. It's an emergency, more energy, no sedation needed. So other procedures we can do, there's what's known as a radiofrequency ablation. And this is where we actually, the doctor goes in and uses a catheter to burn off electrical pathways that are abnormal or not working to create new ones. So kind of think of like pretty much that, like there's some part of the tissue, like because a lot of times it's happening in the muscle where like these signals are kind of getting stuck in a loop, like your electrical signals are getting stuck in a loop. So we're trying to burn those pathways to stop them from getting stuck in that loop. And then we're hoping that the new pathway that gets formed when that one's burned off will actually be helpful, or no pun intended, conductive. And so, effectively they go in and they have to map out where the problems are in the rhythm. And then they try to find, they try to like find all the places where there's problems, and they burn off those. And then hopefully the heart will create new electrical pathways that are actually helpful. So it's done in the cardiac cath lab. We treat it pretty much the same as we treat a patient that went to the cath lab, like for a heart cath. We're going to monitor their EKG closely, support oxygen and perfusion, monitor the blood pressure and vital signs really closely. So effectively just kind of watching for that and letting them know they're going to be sedated most likely for that procedure. So they shouldn't be feeling, they're not going to be feeling their heart being burnt off or anything like that. So overall, what do I do as the nurse in dysrhythmias? My first step, is to go in and assess the patient. If there's a pulse, if there's no pulse, I'm going to skip right to starting CPR, ACLS protocol, ABCs, etc. But if there is a pulse and I'm going to keep moving on and then see, are they awake? What are their symptoms? I want to see how they're oxygenating, how they're perfusing. So I want to see overall how they're feeling. I'm going to check vital signs, and I'm going to determine if the patient is stable or unstable. So remember, the two vital signs I'm going to monitor most closely are going to be my blood pressure and my SpO2, because that's going to tell me how's my cardiac output, and then also tell me, what's my perfusion going, how much oxygenation do I have? And then I'm going to take action again. I don't need to do CPR if they have a pulse, but I'm going to support their ABCs and then contact the doctor to get appropriate orders. So during, let's say that we are doing a BLS, ACLS situation, the patient's heart has stopped. We can take many different roles in a code situation. Our job could be to monitor the pulse. Someone needs to stay and be like, a lot of times we have like a handheld Doppler or something, or we literally have our hands seeing if their pulse is coming back. It also is a great way to monitor compressions, because if I'm holding a pulse, like a lot of times we hold the femoral pulse, or femoral, however you like to say it. And if the person's doing really good compressions, I can feel that blood pumping down to like my hand, like almost like they have a pulse. I can give compressions. When I was really early in my career, I loved doing compressions because I felt really insecure doing any other role. And I felt like it was the only thing I was good at. So yes, but it's very exhausting. Just know it's like a workout. Make sure that you're switching out and not trying to be a hero. I can also manage medication. So I can be the nurse that's giving all the medications to the patient, and the doctors and other people are following the protocols. Usually pharmacy shows up and they're telling me what to give, but I'm standing there and making sure it's going in, etc. There's a recorder that documents everything that's going in. And now they have fancy things in the charting system where I can easily click and document it. But, sometimes we still are writing it down on a piece of paper and later documenting it. In some facilities, you may manage airway, but most places respiratory does that. You also can be a runner. You can go and grab supplies to help out in any way. Or even sometimes it's like there's so many people in helping with the code. We need someone else to check on the other patients, answer call lights, make sure everyone else is okay. And then sometimes you might be a person sitting there supporting the family, because it can be very hard sometimes for them to see and experience this. So overall, my goals are to maintain circulation and perfusion. Remember, everything's about perfusion with these patients, because all dysrhythmias lead to low cardiac output. Hemodynamic stability is a big thing, making sure they have adequate blood pressure, heart rate, oxygenation. I want to teach them when to seek help, how to use device and medications appropriately, make sure that they're going to be safe with them. We always want to get to the bottom of the cause, because I can treat the rhythm all day long, but if there's a cause that's causing it to happen over and over, I got to get to the bottom of causes and conditions. There's EKG, oxygen, and electrolyte monitoring. That's really key because a lot of those are going to affect, again, how well I'm getting perfusion. They may need oxygen therapy. Rest is usually key for these patients. Make sure that they're safe because a lot of the medications they're going to be on and just being in the dysrhythmia itself will put them at risk for having decreased perfusion, therefore feel lightheaded, dizzy, etc. And then my goal is always to convert the rhythm. I always want to get back to sinus if possible, but if I'm unable to do that, I want to control the rate. So I want to try to get to that rate of 60 to 100 when possible. And then I'm going to monitor for complications. So I'm going to be monitoring for blood clots or a common complication of a lot of dysrhythmias. And then hypotension is going to be a common complication pretty much every dysrhythmia, almost all of them. So yes. All right, so there's also this website. They don't pay me to advertise for them, but it's really helpful, called SkillStat, and you can practice your EKG or kind of look it up. And it has like a static one, and then a movable one as well, where you can kind of watch it go by, and they have quizzes and stuff like that. Now, a lot of the rhythms on there are not ones you're going to need to know, but it is good to kind of get to see it in action. I think it helps. So let's do a couple case studies here before we wrap up for the longest lecture ever, right? So we have John. I think it's always helpful at the end to bring it together and see what kind of questions could they ask. So John's 77-year-old. He's got lots of history. I'm not going to go into all that. You can read yourself. But he came to the hospital today. He's having shortness of breath and feeling like his heart is fluttering. Well, that could be a lot of different rhythms. We got to get down to what's going on. So his blood pressure's low. Probably means he's got some dysrhythmias going on. His heart we got a fast rhythm, so heart rate's fast. His oxygenation's low. He's breathing fast. And his temp's mildly elevated. So you listen to his apical pulse and feel his radial pulse. They're irregular. He's lethargic and states that he feels dizzy. His skin is cool, clammy, and pale, so he's showing signs of poor perfusion, short of breath, using accessory muscles, poor perfusion. He's laying in bed on his side and keeps moving to try to get comfortable. So he's really restless and anxious, probably because of the lack of oxygenation. We have a patient in a fast, irregular rhythm. What is a fast, irregular rhythm? That we had to know about. So, what do you call it? More than likely, what is John in? Most likely he's in atrial fibrillation. Let's go ahead and move on to the next one. So most likely he's in atrial fibrillation. What are my priority actions? I want to ensure that he is oxygenating. So his oxygen sats were low. Probably want to give him some oxygen. My goals are going to be to slow the heart rate and convert that rhythm, and then monitor his vital signs closely. Remember, for treatments, my priority treatments, I want to convert or slow this rhythm down so that I'm going to ensure better stability and less chance of clots. And then I need medications to prevent complications like anticoagulation. Two major concerns I'm going to have is a lack of organ perfusion, like they can have decreased blood pressure, decreased cardiac output, and then the fact that they also have those risks for blood clots. All right, number 2. Rachel's 59, history of a bunch of crap. She is at work when she starts feeling lightheaded and dizzy. She's having trouble catching her breath. That sounds like every dysrhythmia. We've got to get more information. Coworker helps her try to sit down and calls 911. When EMS arrives, they find her in this rhythm. So let's see. So let's do our systematic methods. Let's count. 1, 2, 3, 4, 5, 6, 7, 8. 10, 11, 12, 13, 14, 15, 16, 17, 18. A lot of students ask, like, would we count the ones that are kind of half? And generally, as long as part of them is in there, I do count them usually. We're not going to give you a tricky one if we asked you to calculate a rate where we're like, oh, it's on the border. We're going to give you, is it 170 or 180? We're not going to be that mean, I promise. And I make a lot of promises. Maybe I should stop doing that because I'll probably get myself like arrested or lose my job at some point, but such is life. Anyway, so we have a fast rhythm. It is like 180, I think I said. It is a little irregular, but it's not too irregular. It's definitely got some regularity to it, but it definitely looks pretty irregular. It looks at least somewhat irregular. I don't see any P waves, but I have a wide QRS. So as soon as I have a wide QRS, I have to think, okay, it's either VTAC or VFib. And then I have to look at, is it more uniform or is it more wide and like crazy and bizarre? So it's more uniform. So I've got VTAC going on here. So my priority actions are to keep, the oxygen patent airway, make sure she's oxygenating, perfusion. We want to see what are her blood pressure, what are her vital signs. I want to see, is she stable? What's her mental status? Like she wasn't feeling well, but what's going on now? And then the overall treatment, if I have to check if there's a pulse present, I'm going to do medications to convert and or cardiovert that rhythm. If no pulse present, we're going to start ACLS protocol, CPR, defibrillation as soon as possible, and then medications like epinephrine to restore circulation and convert the rhythm like amiodarone. Other procedures or equipment I might need a defibrillator if there's no pulse. And I mean, a defibrillator cardioverts too, but we might do cardioversion if there's a pulse present. And then if she has this as like a regular thing, she may need electrophysiology studies. And I don't have it on here, but it possibly, depending on other stuff she's got going, because I'm trying to think of her history. Yeah, I don't think she has it, but she had like heart failure. We might consider like getting her an ICD or an implantable cardioverter defibrillator. So we got Carlton over here. I'm gonna move my face again. 46-year-old male, no medical history. Doesn't visit the doctor due to frequent fainting spells. His doctor sent him to the emergency room, found his blood pressure to be low at 90/45. He's found to be in this rhythm. So let's do it. We got a rate of 40. It's regular. I've got a P wave, QRS, and a T wave. So everything is normal. And it's skinny QRS, I should say. Everything is normal, except it's a little slow. So what is this rhythm? So this is sinus bradycardia. Woohoo! All right, sorry, I get a little excited, and I've been doing this for a long time, this presentation that is. So I'm actually starting to wane. So I'm trying to hype myself up, in other words. Why is he experiencing this rhythm? So his low heart rate, why is he experiencing his symptoms? So he was having these fainting spells. So you have to keep in mind he's having fainting spells because of the low heart rate causes decreased perfusion to all organs, including the brain, which can lead to fainting spells. So syncopal episodes, it's really common for patients to come in and have bradycardia. And a lot of times what we look at is two things. Do they have a neurological problem, or do they have a cardiovascular problem? It's going to be one of the two, usually with the fainting spells. Treatment, if there's no symptoms, continue to monitor, but obviously he's having some symptoms. So we're going to give him medications to speed up the heart. So we talked about atropine and dopamine possibly, and then he's going to maybe need a temporary pacemaker, and then long-term, he may need a permanent pacemaker placed, and they might do those electrophysiology studies. When I'm saying EP studies, I'm talking about like stuff like where they do the ablation. So I'm not saying he needs an ablation, but they can go in and look at his electricity and see what's going on with these electrophysiology studies. How will we know treatment's working? Well, he's going to say, hey, I haven't been passing out. His blood pressure will go up. He'll probably have an increased level of consciousness, energy, better mood, etc. Last but not least, so Parker, he's a 19-year-old male with a history of drug abuse. He presents to the emergency room with a decreased level of consciousness. The nurse is going to get some supplies to get his care started. When she returns, he's become unresponsive. The nurse checks for a pulse, and no pulse can be felt. So the nurse goes and grabs the crash cart. Other staff members enter and hook Parker up to a cardiac monitor. The following rhythm is displayed. And by the way, after all of these, like, I know it probably looks like I'm just a mess, and I am. I have no problem admitting that. I do go in and fix these for future semesters. So I promise eventually one day I'll have my crap together. I'm just never going to actually record it because I only find out that I don't have my crap together when I'm recording these videos. So anyway, so let's look at this rhythm with Parker. So he lost his consciousness. So we've got this wide rhythm. I can't even measure it. It is irregular. I don't see any P waves, wide QRS, undiscernible. So it's not regular. So if I am not regular and I've got a wide, fast rhythm, I am V-fib. So did the nurse perform the correct initial action? So the first thing she did is he was unresponsive. She checks for pulse, and no pulse can be felt. And so she went and grabs the crash cart. Was that the right thing? The answer is no. She should have started high quality CPR. We're not going to leave a patient alone that doesn't have a pulse. Priority action is defibrillate as soon as possible. As soon as someone else can come in and bring in that crash cart, then we will defibrillate. Other treatments or medications to restore circulation, like epinephrine, or convert the rhythm like amiodarone. And then the other staff, like this is kind of the other people that are in the code situations. We have a respiratory therapist who helps to oxygenate, ventilate, and get set up so that they can get intubated eventually during that code. There might be patient care techs or other staff that are helping with compressions or recording. The charge nurse helps to organize and manage everything. The pharmacy is usually there assisting with medications, giving professional suggestions, and hopefully a doctor's around providing orders and helping to run the code. Depending on your facility, you might not have a doctor there, but usually you're going to want to have a doctor on the phone or something else to help with some of the stuff, because there's definitely ACLS protocol and there's certain meds we can give, but there's also times that we need orders from physicians because there's some stuff that are not a part of the protocol that we may want to do, especially if the code keeps running on. So believe it or not, we survived this. I feel like I've been talking forever, and I'm sure you're tired of hearing me talk, but I hope that this helped. And maybe I always feel like these are so not helpful, but maybe it was helpful for you. I hope it brought you something. If not, maybe a few laughs at how strange and weird that I am. Anyway, see you next time.